Welcome to the slideshow presentation on disseminated intravascular coagulation. This is brought to you through the collaborative efforts of Aletha Garcia, Laura Ishiki, Karen Cross, and Megan Latavish. We would like to start off by talking about background information of disseminated intravascular coagulation, or DIC. It is defined as an inappropriate, accelerated, systemic activation of the coagulation cascade. At this point in our education, we have all become very familiar with the coagulation cascade pictured below. We understand that there's three different pathways: the intrinsic pathway, the extrinsic pathway, and the common pathway. Both the intrinsic pathway and the extrinsic pathway feed into the common pathway, causing an eventual clot. We would like to start off by discussing the intrinsic pathway. The intrinsic pathway is activated in response to blood coming in contact with exposed collagen within the blood vessel itself. Using the pictures as a diagram, the picture on the far left shows red blood cells flowing through normal vasculature without any difficulty. In the second picture, we see that the blood vessel is then exposed to collagen and fibers that are within the blood vessel that cause a response for the blood to start clotting. So platelets come into the area, and we can see in the next picture that the platelets in the blood start to coagulate or clot. At this point, the clot is a thrombus, as it is going through the vasculature without any purpose in some respects. At the end, though, what happens is that this thrombus becomes increasingly larger, and will eventually find its way into smaller and smaller vasculature, thus blocking circulation from the system. The extrinsic pathway is a pathway that is initiated due to damage to the epithelial cells of the body. Tissue thromboplastin, or factor III, is released by the damaged tissue to rapidly initiate the clotting cascade. This is done in order to prevent excessive bleeding. Intrinsic pathway, again, is an internal coagulation process, where extrinsic is an external coagulation process. Internal is much more slow to start off, but then lasts longer, where the extrinsic pathway is much more rapid in its progression, but then also has a very short recovery time as well. Both the intrinsic and the extrinsic lead to the common pathway. It ends on both cycles with the conversion of factor 10 to factor 10A. At this point, they enter the common pathway where prothrombin is converted to thrombin, which then converts fibrinogen to fibrin. The fibrin clot is the final product of the hemostatic process. It is considered stable when it's attached to the vascular wall, such as pictured on the left-hand side, but it's also considered a thrombus when it's floating around in the vasculature. The hallmark of DIC is that thrombus, because it's dislodged and it's going again into that smaller and smaller vasculature, which will again form an emboli. So how is DIC related to the clotting cascade? We've kind of talked about it already, but DIC is characterized by the intravascular activation of the clotting cascade, which leads to the production of intravascular fibrin deposits. In the presence of another disease process, the clotting cascade is activated systemically and becomes a life-threatening disorder of the blood. Macro and microthrombi form within the vasculature, which will eventually lodge in the smaller vessels and capillaries, causing extensive damage to the body and also having embolic events. DIC has been shown to be an independent predictor of organ failure and mortality. There are two different types of DIC. One is acute and the other is chronic. With acute DIC, the normal compensatory mechanisms which prevent excessive clot formation are overwhelmed and clot formation occurs in an accelerated and uncontrolled rate. It develops when there is a sudden exposure to blood to procoagulants such as tissue factor and tissue thromboplastin. Along with excessive clot formation, the formed thrombus find their way to microvasculature and eventually block the normal blood pathways. Because compensatory mechanisms, also known as the mechanisms that stop us from forming clots, are consumed so highly in this process, hemorrhage is also likely to occur. With chronic DIC, this is also characterized by compensatory mechanisms that are able to prevent conceptive coagulopathy and hemorrhage. Blood is constantly exposed to small amounts of tissue factors. Therefore, there's clot formation, but the obvious clinical or laboratory indications of presence of DIC is very minute. Most often, this is seen with patients with cancer, tumors, and aortic aneurysms. Causes of DIC. Now, DIC is not a primary diagnosis. It always has to be in response to a primary disease process that causes an inflammatory response. These disease processes include sepsis, major trauma, complications of pregnancy, large vascular aneurysms, neoplastic diseases like we just discussed with chronic DIC, organ failure, transfusion reactions, vascular abnormalities, toxic reactions, heat stroke, hyperthermia, hemorrhagic skin necrosis, and catastrophic antiphospholipid syndrome. Let's take a look at how a disease process affects the clotting cascade. Sepsis is the main disease process currently pictured in our slide. Let's take into consideration, though, that sepsis can be any of the disease processes which are known to cause DIC. But for simplicity's sake, we'll use sepsis and demonstrate how sepsis, which is an inflammatory process of the body, will cause procoagulant pathways to be enhanced. It allows the body, in some respects, free rein of clot development through the intrinsic pathways and the clot formation within our vascular system. Remember, at this point in time, no damage has actually occurred to the endothelial lining of the cells, and so intrinsic pathways for the clotting process are initiated. Again, leading into the common pathway where factor 10 will eventually lead to the progression and development of the fibrin clot. On the other half of our slide, we could see our anticoagulant pathways. These are the normal pathways of our body, the normal processes of our body to slow clot formation. Unfortunately, in the presence of a disease process, some of those normal anticoagulant pathways are altered, and normal processes are then shuttled back over into the procoagulant pathways, thus altering and changing the anticoagulant pathways, thus leading to impaired fibrinolysis of the clots. Prognosis of patients diagnosed with DIC depends on the severity of the coagulopathy and treatment for the underlying condition. In the setting of major trauma, the presence of DIC approximately doubles the mortality rate of the patients. Other complications include hemorrhage, thrombosis, stroke, ischemia of the vital organs, cardiac tamponade, renal failure, liver dysfunction, pulmonary embolism, respiratory distress, shock, and death. So with a solid background and understanding of DIC, we want to look at how we can put this information into practice. So now we will look at the analysis of the information. We must understand that diagnosis of DIC is made by looking at the entire clinical picture. Through different laboratory tests and a thorough assessment, nurses can play an important role in early detection and prompt intervention for patients at risk for DIC. Some important laboratory values that we would like to talk about are platelet count, FDP, or the fibrinogen degradation products, and the D-dimer, PT, PTT, fibrinogen, antithrombin, and protein C. We do this with the understanding that no single test will diagnose DIC. Laboratory values are essential in offering a clinical picture into DIC. Thrombocytopenia is often seen with DIC, but it's also often seen with other underlying disorders as well. Therefore, it is not specific to DIC. Thrombocytopenia basically means a low platelet count. So we can understand that with this process, why there would be a low platelet count, because platelets are consumed in the process of clot formation. So we understand low platelet count because there's high clot formation. FDPs, or fibrinogen degradation products, and the D-dimer are a product of the conversion of fibrinogen to fibrin. These are the elements that are discarded from the process and do not participate in the clotting process itself. They are typically cleaved off from the conversion, and in the presence of DIC, they are cleaved off at a very rapid rate. The FDPs are typically metabolized through hepatic and renal systems, and we need to take that into account when we see hepatic or renal failure patients, so patients that already have that diagnosis. Often, these serum levels are already elevated in this type of patient, and we must take that into consideration when we're assessing their laboratory values. However, if they are free of those disorders and we start seeing renal or liver dysfunction, we might assume, or we might start guessing, that DIC is present. The two coagulation studies include the PT and the PTT. Again, as professionals, we're very familiar with these tests. The PTT allows us to study the intrinsic pathways, and the PT will allow us to study the extrinsic pathways. As pictured above, the best way to remember it is that PTT, or the intrinsics, are in a relationship, where the PT, or the extrinsics, are separated for PT. PT and PTT are elevated in about 50 to 60% of patients with DIC. PT, PTT also assist in monitoring DIC and the treatments and the therapies that we use. Fibrinogen is another level that we look at. It's typically used in the diagnosis and evaluation of therapy with DIC. However, this test should be used with caution and only in addition to the other labs. It should be a complement. Fibrinogen is an acute phase reactant, so it may be falsely normal in the presence of DIC. That's because you'll see a very high level at the beginning and then it'll drop off, and even though DIC is continuing on. Antithrombin and protein C are other laboratory values as well. Antithrombin and protein C are commonly used in evaluating the clinical picture in the presence of DIC. These levels are often reduced in the presence of the disease. Although independently these tests cannot diagnose DIC, the values hold significant prognostic value to the medical professional. These laboratory values are then put into use through our current practices for scoring of DIC. The International Society of Thrombosis and Hemostasis has become the main method of diagnosis and evaluation of patients assumed to have DIC. It's a 5-step algorithm, the only requirement being that is a patient has to have a condition that we've already discussed. They have to have a condition known to cause DIC. With this requirement, there is a 91% sensitivity and a 97% specificity with diagnosis of DIC. Therefore, this has become the most accurate way to determine the presence of DIC in the state of a disease. So this is the scoring system that we just discussed. We can see that if a platelet count falls within each of those levels, we have a scoring system that goes with those points, either 0 points, 1 point, or 2 points. Same thing with fibrin markers. If there's no change, or if there's a moderate rise, or if there's a strong rise, there's again a numerical value associated with that. We then take a look at the PT prolongation and score that appropriately, as well as the fibrinogen level, which is scored appropriately. Interpretation of the DIC score is 0 to 4 points. DIC is not overt, but we should follow up in 1 to 2 days to make sure that there is no change. If the score is 5 to 8 points, it is likely that the patient has DIC, and we need to rescore them every single day until we see improvement. Care of the patient with DIC. Our basic nursing responsibilities are essential in caring for a patient with DIC. Evaluation of a patient's pain level and treatment. Administration of medications at the correct time. Education of the patient regarding treatment plan. Discharge planning. We always have to provide support and comfort to the patient and the family. Constant assessment of the vital signs of the patient. Assessment of the skin for petechiae and cyanosis of the digits and nose. We also want to assess the skin for oozing of blood. Oozing of blood from 3 unrelated sites, such as a venipuncture site, surgical incision, or a nosebleed, indicate DIC. That is one of the clinical parameters of diagnosing DIC. Also during this time, we should avoid any type of abrasion to the skin, IM injections, shaving the patient. You remember, they are at a very high risk for bleeding, so we want to do anything and everything to prevent bleeding from occurring. Now we enter the conclusions and recommendations for practice slides. Assessment of the patient is a nursing priority. Vital signs, visual inspection of the skin, auscultation of the lungs, assessment of mental and neurostatus, and then of course a constant review of laboratory values. For the skin assessment, changes include, as pictured below, small petechiae, all the way up to very large bruises that cover the body, and then of course we have the extreme cyanotic limbs and vasculature. And again, remember that if you have at least if you have 3 different sites, unrelated sites, on a patient that are bleeding, we can guess, and we need to take a look at the laboratory values of the patient and determine if we have DIC. Any medical therapy directed at correcting the hemorrhaging and coagulation disorder should first look at correcting the underlying disorder. We need to correct that underlying disorder in order to correct the DIC. Remember, DIC is caused because of that underlying disorder, or the primary disorder. Administration of platelets can also be used, but again, it's very conservative in nature. We have to look at if the patient needs an invasive procedure to correct that primary disorder, or is actively bleeding and hemorrhaging, and their platelet count is lower than 50,000, the need to transfuse platelets is of utmost importance. Of course, if the patient is not bleeding and they are moderately stable, the threshold for administration of platelets should be reduced to 10,000. Less than 10,000, your risk of spontaneous bleeding dramatically increases. So we need to, again, know and look for those signs and symptoms of spontaneous bleed. Use of cryoprecipitate or FFP. When a fibrinogen count is exceedingly low, less than 1 gram per liter, even after infusion of fresh frozen plasma, the use of fibrinogen concentrate or cryoprecipitate should be considered. There is no data that demonstrates use of this therapy improves the patient outcomes, but it is still one of those therapies that is currently in practice. The use of tissue factors. Recent studies have focused on the tissue factor 7A complex, a member of the nematode family of anticoagulant proteins, or NAPs, and an inhibitor of the complex. Between tissue factor and factor 7A, and NAPC2 has been observed to inhibit coagulation activation in the primate models. Other research has used antibodies against tumor factor 7A with promising results. Recombinant factor 7A has also been demonstrated to be useful in the cases of severe bleeding. It, however, has a powerful procoagulant effect and should be used carefully throughout administration. Antifibrinolytic agents such as the aminocaprotic acid or tranexamic acid can be considered in the case of active bleeding, but should always be used with heparin. Heparin is thought to inhibit activation of the anticoagulation cascade and prevent formation of clots. There are no studies that demonstrate an improvement of DIC with the use of heparin. Heparin, or low molecular weight heparin, is only considered when patients are critically ill and not bleeding. Inflammatory processes. Lastly, recognition of the importance of inflammation in both sepsis and DIC has led to further investigation of inhibitors of inflammation in the use of therapy. In a murine model, researchers showed that anti-selectin antibodies and heparin blocked leukocyte and platelet adhesion. Similarly, focus has been placed on interleukin-10, an anti-inflammatory cytokine that may have effects on coagulation activation. Initial studies of the IL-10 have shown promise in preventing coagulation activation associated with endotoxemia. Other researchers have targeted P38 mitogen activation protein kinase, or MAPK, an important element in intracellular signaling responsible for inflammatory processes. Inhibition of the MAPK has been shown to reduce coagulation activation, fibrinolysis, and endothelial activation in endotoxemia. Collectively as a group, we would like to thank you on watching our slideshow presentation on DIC. We hope that it will benefit your patients and your practice in the future. Thank you.